Health is everything, whether you're talking about housing, education, justice, social services, your local council. Health runs throughout everything because we both all need to keep healthy, exercise and avoid sickness. So who better to talk to today than TV doctor, Dr. Amir Khan, who is also a practicing GP.
Hi Zack, it's a big day today. I'm meeting the boss to give him an update on EcoTalk. But I'm feeling good. Spring's in the air, feels like the new year's really starting, and good things are coming. If your listeners want to do a good thing, they should switch to EcoTalk. Then they can be part of helping nature. All they need to do is go to ecotalk.co.uk/boldpolitics to find out more.
Thank you so much for being here. I'm incredibly excited to have you. I said to you before we went on that I was going to start with, if someone doesn't know who you are, and I don't imagine there's many people who don't know who you are, because if they turn on a TV, you are often on it talking. But who are you and what do you do?
I'm sure there's plenty of people who don't know who I am. I am an NHS GP. Sorry, I should actually say my name first, should I? So I'm Dr. Amir Khan. I'm an NHS GP based up in Bradford. I'm also a broadcaster. I'm on ITV's Lorraine and Good Morning Britain. Author, activist, I would like to add to that as well.
There are lots of skills there. I guess I'd start with the activist bit though, actually, because I didn't know you would describe yourself that way. Have you been kind of active in terms of health activism for a long time, or is it a kind of newer thing?
No, health activism has always been a passion of mine. I think anyone who is serious about health needs to be an activist, because health is politics, it's policy. People's health is decided by how much funding an area gets, how much that gets in the community, not just in the NHS, what the food prices are like for them, what access they have to green spaces, what access they have to clean air, what access they have to education. All of that determines people's health. And I think if you are really passionate about health, you've got to get to those root causes to have good health outcomes. But beyond that, I think it's about making sure the people that you're looking after, and beyond that, because I think as a doctor, you shouldn't just care for the people you're looking after. It goes wider than that, I think. And when you see healthcare professionals being bombed, attacked, all those things in other countries, you've got to stand up against that as well.
So there was a lot there. That was amazing. And we often hear about this phrase health inequalities, and I felt like you were touching on it there. How unequal is healthcare outcomes in this country in particular?
Incredibly unequal. You've got an NHS that has been battered and bruised, particularly since the 2010 onwards. We've seen a huge drop in funding, and anything that does that widens the health inequality. So we see people who are living in poverty have much more difficulty accessing health, and that's for a number of reasons. Yes, in terms of getting a GP appointment, waiting lists in hospitals, all of those factor into that, but also the lives that they are made to live through, not through choices of their own, but because of policies that go beyond them, mean that they don't have access to all those things I listed before: good quality food, clean water, access to clean air, things like those green spaces I talked about. All of that widens health inequalities. But what it does mean is those who can afford health, and where the NHS is failing, they can afford to go privately. So you see that massive, massive health gap there.
I often hear politicians say that the NHS will stay free at the point of use. But this is at the same time as giving contracts to private healthcare companies. There's kind of a gap there. What is the gap?
So the push for private health within the NHS has come from a drive to want to kind of push down the wait times within the NHS. And that is because we haven't invested in NHS infrastructure, staffing and service. So there's been a real gap between the demand that is needed and the capacity we have. And a quick fix for that is to say, right, let's just give these contracts out to private companies who can help us with this. But the issue there is then these private companies really root down within the NHS, and it's hard then to pull away from them. But the big issue I have with it is actually giving these contracts to private organisations does destabilise the NHS service as well. So I always use this example. We have two patients with a hernia that need operating on. One is really fit and well and just has a hernia because he's been to the gym. And the other one has multiple health conditions like diabetes, COPD, chronic lung disease, heart failure, all of these things. So you've got these two patients, but they both need their hernia operating on. The private company will not touch this patient with all these conditions because they don't have the facilities for the aftercare after they've done the operation to look after all those other health conditions that could become complicated after the procedure. And that operation and looking after them for longer will cost them so much more. The other person who just needs a hernia op as a day case and will go home, they'll go, all right, we'll take that. The complex one goes to the NHS service. Both the NHS and the private organisation gets paid exactly the same to do that hernia op. But you can see the NHS is paying more here to look after this patient. I'm not blaming the patient, it's the system. And so all the relatively easy, straightforward patients are creamed off for these private organisations because they say, well, we can't do these complex ones because we don't have the right equipment to look after them before and afterwards. So they'll take all the easy ones. The more complex ones that need more complex care get done by the NHS. They both get paid the same. Eventually, the NHS will go, actually, this is really bankrupting us because we can only do a limited number of these because that patient stays for longer. And so we're not going to do this operation anymore. And that private company goes, right, okay, we're the only player in this game now, so we're going to up our prices if you want us to do this. It's the same procedure, but there's no competition anymore, so up the price it goes. And that's a real issue within the NHS. So when we give people private contracts, yes, in the short term, patients go, great, I can go here, here, and here, and I'm not waiting as long. In the long term, it really does destabilise the NHS.
And then we have, I'm not pulling you into party politics because you're a doctor and we shouldn't mix doctors and party politics.
Health is politics.
Quite. But we can talk about the plan. And Nigel Farage we don't exactly know what the plan is, but it seems to be increasingly moving towards a point-based private healthcare system. What's your opinion of the plan?
So I have heard this, and I think people really need to understand what an insurance-based healthcare system looks like. And there's two models, really. So there's the US model, which is a private insurance-based model, where the government isn't really that involved in negotiating anything and people have to pay privately. Yes, there is the Affordable Care Act as well in America. But what you need to understand is because people are paying such high amounts, because the government has not negotiated any prices for medicines, procedures, all of this kind of stuff, these private companies and healthcare companies and pharmaceutical companies really skyrocket their prices for things because they know the insurance companies are going to pay. When you look at America's health outcomes, first of all, they pay more GDP for their health, so it's more expensive for them to pay for their health. But their health outcomes in terms of life expectancy, infant mortality, chronic disease management are far below ours. And they're paying around 17-18% GDP for their healthcare. We pay about 10 or 11%-ish. And so that massive discrepancy between cost, but the health outcomes are so much poorer. And if you speak to anyone there, health costs are one of the number one causes for bankruptcy in America as well. So it's huge. And you've got people delaying access to health because they can't afford it. You've got people not taking their medication or rationing their medication because it costs so much money there. And so when you look at how it works in America, they're paying for it themselves. They've got worse outcomes. Of course, the health and wealth divide is huge over there. That is a terrible system. It's not a system that we want anywhere near here in the UK. People often say, well, actually, if you look at other European countries, they've got insurance-based policies like Germany and France and the Netherlands. Well, actually, it's very different there. They have like a social insurance policy where the government heavily subsidises their healthcare. So Germany, for example, 70 or 80% of the healthcare is subsidised by the government, and they may have to pay a little bit for insurance, but a lot of it is claimed back as well. And so it's very different to what's going on in the US. Either or, the government is paying, whether it's the NHS or whether it's these social insurance companies, it's taken out of taxpayers' money. And the answer isn't insurance-based policies here, because I I don't think when certain politicians talk about insurance-based policies, they're talking about Germany, France and the Netherlands. I think they're talking more like the US, where there's huge profits being made by private organisations at the expense of people's health. And that is something that we just have to avoid. That is not what the NHS is about. The NHS is not about massive profits. The NHS is all about health outcomes and doing the best for patients. And if we move towards that system, our position in terms of healthcare, but our position in negotiating prices for drugs and treatments really is going to be really affected as well, because it's all going to be privatised and it's just going to be awful. And I've got to say this, and I say this with such passion. I am NHS through and through. I don't do anything but NHS work when it comes to health. Once the NHS is gone, it is gone forever. We will never get it back. Don't think, oh, well, we'll try it and see. And if it doesn't work, we'll get the NHS back. You will not. And you will regret it. And it will affect generation after generation. I could cry when I'm saying this. Generation after generation after generation. It will never, ever come back. And so please, 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 protect the NHS and vote accordingly.
It's literally one of the best things about this country.
Yeah.
And hasn't been loved for a long time, but actually it seems so strange to throw the baby out with the bathwater.
Yes.
Or it doesn't seem strange when you realise what someone's motives are for doing that. And in terms of the NHS is failing, I was going to say, what is the state of the NHS in your kind of diagnosis?
It's a really hard one. I would say the NHS is really struggling, not because of the people who work in it, not because of the people who use the service, but because of years of austerity and underfunding. So if you go back to, consistently since the 1950s till about the 2000s, we saw a steady increase in the funding that the NHS gets, around 3.9% increased funding per year. We did then see a boom between kind of the 1990s, 2000 up to about 2010 with the Blair Gordon Brown government. We saw an increase in spending and a lot of the infrastructure waiting lists and all of that went down. Since about 2010, after all the austerity cuts came in, we've seen a steady decline in the funding. Yes, it's still going up year by year, but compared to that 3.9% average per year, we're now seeing a funding increase about 1 to 2% per year. And that's had huge effects on the NHS. First of all, we haven't invested in the staff. We're seeing record numbers of NHS staff leaving the NHS for a number of reasons, including pay, including working conditions, including the quality of care they can give their patients. And that is one of the reasons they got into that job. The infrastructure hasn't been invested in. Community health hasn't been invested in. So all of those things have led to an increase in wait times, difficulty accessing care. But we're also seeing an ageing population at the same time. We're seeing increasing complexity in care. Certainly as a GP, I get 10 minutes, sometimes 15 minutes to see really complex patients with multiple health conditions and underlying mental health issues as well, and underlying social health issues as well. So all of those things we're expected to bottom in 10 or 15 minutes. It's impossible. And that patient then has difficulty getting a follow-up appointment. So it's a bit of a vicious circle. So in terms of where the NHS is right now, it's in a really precarious situation for both staff and service users. And what that means is there are what I would describe as sharks circling, pushing for perhaps privatisation, pushing for an insurance-based system, which would be a disaster for everyone.
I definitely want to get back to that.
Yeah.
I've had a strange insight into the 10-minute consultation appointments because before I was a politician, you probably know this, I was a theatre actor. And one of the ways I was making money in terms of my bread and butter was doing medical role plays. And so when people were doing their final exam to
Yes.
be a GP, they would come in and I would have a kind of script that I would have to do.
I would love for you to be my actor when I did that exam.
I just used to love it. But you kind of sometimes do like 50 of them in a day.
Yeah.
So you're just having the same conversation over and over again. And you're
Yes.
like, have I said this already? But I saw how difficult it is for people to get the amount of information you need to get in 10 minutes. And presumably, and not just older people, I suppose younger people can do this too, but sometimes people really want to talk and they want to tell you their whole life story. We also know we've got a loneliness epidemic.
Yeah.
How as a GP do you balance kind of the empathy and the connection of a human being and get the information you need to get and have them out of the door in 10 minutes? It just seems wild.
It is wild. And I think it's almost impossible, because the odds are stacked against you. I'm a GP trainer, so I've been training GPs for 13 or 14 years now. I've currently got 3 trainees that I'm working with as well to get them ready for that exam.
Amazing.
And so they really struggle because you do want to talk to the patient. You do want to get all the information out, because within all those stories and what the patient wants to tell you is the nub of their problem. And their problem doesn't exist in isolation. It exists within their life, within their community. And we need to know how it's impacting all of those things at the same time, so we can get a management plan that suits them and not just that one particular illness. We are trained to ask certain questions to get all of that out. And I would say, I've been a doctor for over 20 years now, and it was easier before when the complexity wasn't there, where all these social issues didn't play as big a role as they do now, and all the cuts that have happened in the community didn't play as big a role as they do now. But now it's really difficult. And even I would describe myself as an experienced GP. I've been a GP for over 15 years. Find that time restraint really hard. And so you have to pick and choose. There are some patients that you can get out the door quicker because they've got a simple-ish issue, but there are those that need your time, and you have to connect with them in a different way and really explore their issues. And I think you've got to be okay with running overtime as well. That's what I do. I've made peace with it now. And I think if patients want to come and see me and they want, or a doctor who gives them the care that they want and they need that time, then they have to understand that other patients need the same time as well.
Do you have, I'm missing a point here entirely, I'll get back to the important stuff in a minute, but do you have people who book an appointment and they don't know that it's you, and then they walk, I mean, it would blow my mind if I walked in to see my GP and you were there.
All the time.
Okay.
But the thing about my surgery, I've been at that surgery longer than I've been on TV or writing or anything like that. So I think they've laid claim to me before all this happened. So to me, it's just like, oh, it's Amir on the TV again, but he's my GP. And it's also the area I grew up in. So they know not just me, but they know my mum and they know my sisters and they know my family. And often if they can't get an appointment, Zach, they text my mum. They do. And then she texts me and goes, oh, would you mind at the end of your surgery just slotting in so and so? So my lists are about 10 times longer than anyone else's because I don't want to annoy my mum.
I love that your mum's like the part-time receptionist for your work as well.
Pretty much.
I should say director as well as receptionist probably.
Yes.
And the kind of, obviously Google isn't a new thing, but I just even think about my friends and family, in fact myself, let me not even put this on my boyfriend for instance, that we Google what we think is wrong with us and then we go in to talk about the GP and we're absolutely convinced that something is much worse than it is because we've read some of the darkest corners of the internet.
Yeah.
Is that a real issue?
It's not an issue. I don't mind exploring people's concerns. And often, whether you Google things or not, if you've got a headache, if you've got an unusual pain, your mind naturally goes to, God, this could be a brain tumour, it could be something serious. And Google can sometimes reinforce that belief. But actually, explaining why it's not that, or actually let's do some tests to make sure it isn't that, is actually quite a useful part of the consultation, because it's one way for patients to tell us what they're actually concerned about. Because it's easier to say, well, I Googled this and this is what Google said, and I know I should never Google it, but this is what Google said. It's easier for them to say that than it is to, well, actually, I did actually think my headache was a brain tumour, without kind of that backing of Google just to second them a little bit. So I don't mind it so much. It gives us a way to explore patients' concerns.
You're so relentlessly positive. It's beautiful. I can just feel the relentless energy. Is ChatGPT, I mean, it's a similar question, but I know people are using this sometimes now for mental health counselling, which sounds worrying as well, but presumably as well for GP diagnosis.
The issue I have with AI is not that it might tell patients what it could be. It's that it might falsely reassure them.
Right.
And so they don't seek healthcare advice, a real healthcare professional. In terms of ChatGPT and mental health support, we already refer people to online courses and online services for mental health as a result of, it's really hard to access actual face-to-face, in-person mental health support. So one way to kind of get around that and give people the support they need in the meantime is to say, well, actually have a read of this website and go on this online course. So ChatGPT is one way to do that. The issue is who's regulating it? What information is on there? Where is it getting it from? How reliable is it? And will it really help people? The websites that we refer people to are highly regulated funded and written by healthcare professionals, not an AI chatbot. And that's a big issue for me.
Yeah, it makes total sense. Coming back to kind of the initial, more holistic view, it's a good word, of the NHS. Very often I'm on TV or radio and I say we need to fund the NHS, we need to invest more money. And after they've asked me where's the money coming from, we talk about wealth taxes and various things.
Yeah.
The next question is it about funding or is it about efficiency? And I'm just wondering what your thoughts are on that. I think it's about both.
I think it's about both. We've got the very clear evidence from when the NHS was funded properly, compared to now. They averaged 3.9%. It went up to almost 9 or 10% during kind of the 90s to up to 2010. And we saw the wait times come down. We saw people get better access to their GPs. We saw health outcomes improve as well. So we know that funding works. Efficiencies are important as well. At the moment, we're just not funding it at the level that it needs to be funded at. And there's a lot of shortcuts taking place. Rather than funding NHS infrastructure, we are giving contracts to private organisations to come and work in the NHS and get contracts within the NHS, which is an issue for me. And so the answer lies, as you say, better funding, better efficiencies, but looking at the root causes of health issues as well. At the moment, it feels like we're constantly firefighting. Bed capacity in the NHS on average is 94%. So that flow of patients out of hospital so we can get elective care done, so we can actually look after the patients that need it and put patients where they need to be, because they don't all need to be in hospital. Over the austerity cuts, we've seen a lot of these intermediate hospitals close, and those were really useful. When my patients in particular, when they were done with their acute care, they could spend, particularly my elderly patients or those living with frailty, would spend 4 to 6 weeks in a rehab hospital where they had intensive physio, OT before they went home, so they wouldn't just bounce back into hospital. That isn't happening anymore because all of those intermediate community hospitals, well, I say all of them, a lot of them have just been closed. That access isn't there anymore. So patients go home, perhaps unsafely from hospital because there's a pressure on hospital beds. They are supposed to get care at home through these kind of physios and OTs who come home, who are themselves amazing but stretched to the max. And so they don't get that intensive one-on-one care. They might get a half-hour appointment with a physio who comes to their home very quickly. And because that physio has to go somewhere else and somewhere else and somewhere else. So all of those things are being lost at the moment. So we've had the funding cuts, we've had the cuts in community, infrastructure, primary care. We deliver 90% of NHS care. We only get 10% of the budget. We're losing our staff as well. And all that wraparound social and community care has not been invested in. And all of that over decades, successive governments just making cut after cut after cut has led to where we are now in the NHS.
I confess I hadn't heard that stat till you've just said it. So 90% of healthcare is primary care.
Yeah.
And only gets 10% of the budget.
That's right.
I mean, that's not justified, but has there ever been any justification of why that is?
I think we're kind of seen as the runt of the litter when it comes to the NHS. And so, yeah, of course, hospital care is far more expensive. So it makes sense that they get the lion's share. But that discrepancy between 90% versus 10% is huge. And it doesn't take into account all the work that we could be doing in the community. What patients want more than anything is to not be in hospital. They want to be looked after close to their home, close to their loved ones in the community. And that involves primary care, not just GPs. GPs are one part of primary care. We're talking about district nurses. We're talking about home visiting teams. Like we've got brilliant heart failure nurses that go out to people's homes, keep them out of hospital by looking after their heart failure, adjusting their medication at home. We can do that for so many other systems. Respiratory cases. When you look at the winter, we see people with existing respiratory conditions go into hospital because they become acutely unwell. But if we had a system that looked after their respiratory condition at home, rather than that once a year appointment they might get with their practice nurse just to make sure they're using their inhalers properly. Practice nurses do amazing more things than that. But it could just be so much better managed in the community. But we are so stretched right now, firefighting, at the moment where GPs are currently disputing the government on the current, or this new GP contract that's coming, that's suggested that we have to see all patients every day, no matter how many numbers come in. We can't cap the number. We have to see every urgent case, every non-urgent case. We have to deal with it there and then. When we haven't got the capacity to deal with it, where are we going to put those people safely? How are we going to look after those people safely? But we're constantly being battered and firefighting that this long-term preventative chronic conditions just don't get the care that they need.
And can I ask you, I suppose it's a follow-up question about adult social care or social care more generally, because presumably when that's not being funded or managed properly, effectively with the patient at the centre of it, you also end up with the brunt of that too.
Yeah, very much so. So, I go on home visits. When I'm at the surgery, I will do 1 or 2 home visits over lunchtime. And effectively, they are housebound patients. More often than not, they're elderly, frail patients. And many of them would be better looked after, even by their own admission, in social care of some sort. So whether that is a nursing home, a residential home, or having carers come in at home, getting access to that is so incredibly difficult. First, getting access to it as a kind of a pre-planned thing, going, right, I think this patient would benefit from some care at home or needs some 24-hour care in a care home, and the patient has agreed to it. Organising that, even in a non-acute emergency situation, is really difficult. The amount of admin and phone calls I have to make that happen, and it takes days, is just huge. But if there's an acute emergency where someone's wife may ring up the surgery and say, look, I just cannot cope with looking after my elderly husband with dementia anymore. I just can't cope with it. I've had enough. Today's the day. That is it. Trying to sort that out in and amongst, a full surgery honestly, I can't tell you how much time it takes up. And there's just no joined up services in that. But if adult social care was working well, and then we could say, right, we need a single point of access. This poor woman has been looking after her husband for so long, and she's really struggling, and he's becoming increasingly confused, perhaps even violent, through no fault of his own. He's got Alzheimer's dementia. We need something now, right now. And that whole team would just go in there and take care of it. That's the ideal situation. That is not happening right now.
It's so frustrating to watch, because whether it's the kind of effective cuts on primary care, or even frankly the police who are dealing with issues that probably social care could have prevented in the first place, It just feels like the scrimping and saving of money actually creates much worse consequences later on. Very much so.
And people are feeling that. I see it every single day at work, whether it's access to dentists for children. They come in with dental issues to see us as GPs because we're slightly easier to get into than the dentist. Or anything, all those social care issues. I can't look after my partner or husband anymore. My mental health is deteriorating. All of these kind of things where if we had better community centres, better mental health services within the community where people can get same day mental health care, that would just be incredible, and it would take a massive pressure off us so we can spend more time with the patients that really need it, those really complex patients with multiple health issues, that actually rather than 10 minutes, why don't we spend half an hour with them and really sort out their problems, and everything else that we were doing that we don't have to do could be taken care of by someone else.
For sure. That's so well put. And so then I want to link to long-term health conditions, and particularly long COVID. And actually it feels particularly poignant speaking to you because we had an amazing Green Party councillor, Darren Parkinson from Bradford, who publicly stepped down because he had long COVID. He's still doing amazing work. He often supports me and helps us with our communications on social media. So thank you, Darren, for everything you do. And at the same time, I think, I don't want to speak for Darren, but lots of people who do have long COVID just feel they kind of have been left behind and there's nothing for them and they're not in the public discourse.
Yeah, very much so. Long COVID is a really poorly understood condition, and it's a multi-system, complex issue, and it will affect everyone differently. Everyone has a different version of long COVID because it is so multi-system. It is so inflammatory. It can cause so many different things to go wrong at the same time, and you're left with these conditions that nobody really wants to touch because there hasn't been enough investment in the understanding, but also the management. And there used to be a long COVID service at most hospitals where it was run by the respiratory team, perhaps, and they would take care of it. All of that seems to have just melted away. And because, like I say, long COVID can affect your brain, your lungs, your skin, your joints. It can affect so many things, your mental health, but also how fatigued you are. We haven't got one group of people looking after it. If I saw a patient like that, I would have to refer them to the rheumatologist just for their joints. I would have to refer them to respiratory people just for their lungs. And it's just not adding up. So not only have we got these people who were really well and healthy a few years ago who are now, very affected by their symptoms, and a lot of them have lost their independence and their ability to earn as a result of it. We haven't got anything in place to look after them. And that, we're talking about adults, but it can affect children as well. And so it's a real problem. They come in, I feel really helpless when I see them, to be honest with you, Zack, because I know it's one of those consultations where I know, yes, I can listen to them and yes, I can empathise with them, but there's very limited things I can do to help them, because giving them painkillers isn't going to be the long-term answer. And we don't know enough about the condition to know which specific medication might help reverse some of their symptoms, and that's a massive issue for them. So they have been left in limbo. But it's not just them. It's other conditions where we've seen a lack of understanding and investment in. So fibromyalgia being another one, ME being another one as well. All of these things that have such a kind of multifactorial cause. And we can talk about women's health in the same space, can't we, really? Endometriosis, adenomyosis, all of those things that haven't been prioritised for so long. People have just been left. And it's really hard because we see them, we listen to them, but it's so limited for what we can do.
I feel very emotional listening to you, because I find it one of the hardest things to handle as a politician when people write to me, particularly with long COVID, but actually, frankly, yes, all of those conditions, because it feels like my obvious first step is to argue for more funding, to look at more steps for prevention, to make sure there's proper ventilation in buildings, etc. But it also just feels like the decision makers very often, unless they've got someone in their family or they've been personally affected by it, there seems to be almost this psychological thing of, it won't happen to me, and that's unfortunate for that group of people, but we're just going to get on. Yeah,
and I think that's where the issue lies for a lot of health issues. Unless they are in the public domain and of interest to the public, then they don't get the recognition and the funding that they deserve. And there's so many health conditions like that. But that's where I think this joined up health service needs to be better. It is so fragmented for people who have these multiple conditions or conditions that affect multiple systems. They often get various appointments with different specialists, but nobody's really talking to each other. So I'll speak to a patient who goes, well, I've got an appointment on Monday and I can't come to your appointment on Tuesday because I've got this letter and I don't really know who I'm going to see or what I'm going for, but I'm going here. And it must be so difficult for them to go and see a specialist every time. And yes, they're lucky to see a specialist. Well, I say lucky, it's absolutely their right, but they feel lucky, but nobody's really talking to each other, and it's just not joined up in the way that it should be.
And then I'll start with the personal stories in a moment, but my partner, who's a physio, so shout out to the allied health professionals.
Yes.
I watched his father slowly disintegrate because he had pulmonary fibrosis, and there's an amazing group called Action on Pulmonary Fibrosis who do a lot to educate particularly doctors who can miss the symptoms at the very beginning of it. This isn't just about pulmonary fibrosis, though. I suppose there's lots of conditions. As a GP, how can you possibly know about every condition? But is there more that politics could be doing, maybe, or is it this very much within the health sector about education?
I think there's a number of things there. Yes, as a GP, we can't know about everything, but we should be able to recognise when, even if you don't know what it is, that something is wrong and needs further investigation. I certainly don't know every condition and how every condition is going to present, but I feel like I owe it to my patients to know, actually, this isn't normal, so let's do some tests and find out. And if I still don't know, I should be able to hand over that patient to an expert who might know the answer. I think where it can fall down is if you don't know the answer, but you don't investigate it either. And so that is important. I think, yes, absolutely, we probably do need some more training in certain conditions. Women's health, I'm really passionate about women's health, and I know it doesn't get the attention it deserves, but that we can say the same for lots of conditions. And whether the not just the undergraduate medical training needs looking at in terms of that, because, you shouldn't just do 4 weeks of women's health. They make up 50% of the population. We should be doing a lot more than that. But the GP training as well, how are we actually making sure that these conditions are being taught? Is it, are we just leaving it to the trainers in those tutorials? Are they getting any formal teaching in it? How is it all being examined? We need to make sure that women's health does get examined at every opportunity. We need to make sure that some of these rarer conditions, these students and GP trainees or resident doctors know that they could get a question on that, and so they do need to learn about it. So I do think that, but all of that comes in hand with politics, right? Because the changes need to come from policy and pressure from policy makers, so we can make those changes. We're all amenable to it. We want to learn more as clinicians. We're always wanting to learn more, but it's finding the time and the space to do it, and making sure everything gets a fair footing. It doesn't have to be equal footing, because some things present more commonly than others, but they should be a fair footing.
And you stole my next question, which is great, which I was going to say, women are over 50% of the population. Why is women's health not being prioritised or given 50% of the attention? Where
do I start with that? Well, historically, everything's been done by men, right? So all the studies on medical conditions, whether it's heart attacks or pain management, all of that stuff has been done on men. And so we've just assumed, I say we, not you and I, but men before us, have assumed that women are just small men, and we can apply the same outcomes that we found on men to women. That is absolutely bollocks. It's just bollocks, because women are a completely different, but have a different biology to us, with their hormones, with their pain receptors, with their anatomy. Everything, all of that is different. The way estrogen affects almost every part of a woman's body will mean paracetamol will affect her differently to what it would with me. So that has not been really investigated or understood or wanted to be understood until quite recently. And we've got to give a shout out to all the people who, and mainly the women who are being pushing for this. All these kind of gynecological issues like endometriosis or fibroids, adenomyosis, all of these things where women have been just told, well, that's just being a woman, put up with the pain, it's just part of the cycle, and you just got to get on with it. Actually, no, periods are normal, but very painful periods are not normal. Bleeding in between your periods isn't normal. Heavy periods are not normal. All that pain that you get because of these underlying gynecological conditions, where it's just been put down to, oh, it's just a woman. It's not normal. And so women have just been gaslighted in believing that their very painful, very debilitating symptoms are just part of being a woman by men for years and years and years. And of course, the studies that we have for lots of things have just not included women. They haven't included pregnant women. They haven't included breastfeeding women. So we don't, so our fallback is, oh no, well, a pregnant woman can't have that, or a breastfeeding woman can't have that because it's unsafe. And that isn't necessarily true. It's just that we don't have the data because we haven't done the studies on pregnant or breastfeeding women to say that they can or can't have something. And so women's health now, I think, has, women are standing up quite rightly. We're talking about vaginas and vulvas and all of that stuff quite rightly. We should be. And we are hoping to be working towards, I'm hoping, some like women's health hubs in the community where we can look after women from cradle to grave. And really, so a mum could take her daughter or her own mother to this same place, and they could all get treated at the same time for whatever thing they have, because women's health is so much better understood. I'm
feeling really fired up listening to that. I imagine other people will. There might not be something obvious, but are there any campaign groups or obvious places that people can go to find out more about that and support it?
Womenkind Collective is a really good one, and there's a lady called Dame Leslie Regan who's doing a lot of work in women's health, and I would urge you to see what she's writing about, because she's the champion for these women's health hubs.
I'll definitely check that out, and I hope other people will too. Yeah. I'm not trying to pull you into very complex conversations, but I'm interested in the process. Okay.
Yeah.
So I was on a podcast on Monday in front of a live audience, and the podcaster took issue with the fact I'm vegan and started to ask me, do I miss the taste of meat, and all sorts of like pretty offensive questions. It was a comedy show, so I kind of kept a smile, but a little bit of me was like, these are odd questions to ask. But the bit I found more interesting was that they had recovered from cancer, and said that their doctor had told them to start eating more chicken because it was going to help with the cancer. There's also a group I'm very aware of called the plant-based healthcare professionals, so a group of doctors, nurses, well, healthcare professionals, including in the title, who are pushing for more plant-based options, particularly in healthcare settings, but more widely. The bit I'm less interested in is, should everyone have a plant-based diet? Because I think we could do a whole hour on that. Where should people be going for information, though, I suppose, and who should they be listening to?
That's a good question. I have to declare that I'm vegetarian as well. And I think either as a vegetarian or a vegan, you can get all your nutrients from plant-based food. There's no doubt in my mind about that. Yes, it's also possible to eat really unhealthily as a vegan and a vegetarian, isn't it?
So I'm right there, I'm afraid.
We know that.
I won't tell you about my diet.
But you can absolutely get all your nutrients from plant-based foods. You just got to understand how to do that, and that's important. In terms of where you can get information from, it's always trusted sources, isn't it? You will always go online and you will find people who look amazing, go to the gym all the time, and they claim to be on certain diets and they're doing this and they're doing that. And because they're so physically appealing and they're talking with such authority, it feels like what they say, if I do what he or she says, I will look like them and I will feel like them. It's just nonsense. You know, they are showing you one thing that they want you to know, not the whole picture. And I think if you really want information, go to proper healthcare professionals. And I'm not saying that's doctors, because, you know, we don't know everything about nutrition. We certainly don't. You know, a lot of my knowledge comes because I am a GP with a special interest in diabetes. So I had to do a whole module around nutrition when I was doing my postgraduate diploma in that. However, I would say that most doctors have quite limited knowledge in nutrition specifically, and so a dietitian or a nutritionist is your best bet. And they have there's lots of people online who give really clear advice on nutrition. And whether that is, if you want to do more plant-based stuff, plants are great, loads of vitamins, lots of minerals, lots of polyphenols. Honestly, walnuts, berries, legumes, they're like the triangle of good health for me. But I have to say this as a doctor, you know, when I'm talking to my patients about food, and I know they're not vegetarians, which is absolutely their choice, I will talk to them about the benefits of fish. I will talk to them about the benefits of lean meats like chicken, but I will also tell them, you know, eating too much red meat can increase your risk of bowel cancer, or processed meats as well. And so I do have to be fair when it comes to that, because fish is a really nutritious thing. For me, it's not about the nutrition, it's about the ethics of eating fish. And so I do have to be very clear. But yeah, nutritionists and dietitians are your best bet when it comes to nutrition advice.
My response is always, I'm a politician, not a healthcare professional, but I can be more specific now about who people should go and see. So last week I was at a report launch for Transactual, who are a trans rights organisation who are talking about the kind of discrimination that trans people are facing across the kind of board. But one of their particular asks was around healthcare, but not trans-specific healthcare, but actually when you go and see your GP, the GP understanding that a trans person is a person too, and if they've got a broken arm or a leg, it's not necessarily because they're trans, but also the same need as gender-affirming healthcare. What more do you think needs to be done?
I think there needs to be very specific training in this. I've had zero training in looking after people from the trans community. I would like to think I do it well when they come and see me, but I'm just guessing I do it well. I haven't had any feedback based on that. You know, we will always ask them how they, what they'd like to be called, and I like to think I look after them as a person rather than a trans person, But I don't know. And the issue I have with that is that I haven't had any training. None of my trainees have had any training. I don't think we get any at medical school either. You know, I work closely with Leeds Medical School and I'm not sure, I can't say for sure, but I don't think there is any in there. I think it's kind of optional. Oh, if you see a patient, then write about it and reflect on it. I think it's that kind of thing. But I do think definitely the medical curriculum, undergrad and the nursing curriculum, you know, all of the healthcare curriculums, undergraduate and postgraduate, should have some training done by trans people,
Right.
written by them, delivered by them, not by people like me who's just guessing. It has to be done by them so we can treat them with the exact kind of care and dignity that they deserve and they want more than anything.
It's really beautiful to hear that. I suppose it's for nothing about us without us. It's like feels quite simple, but so often is missed. You mentioned earlier that lots of doctors are thinking about leaving the NHS, and this is one of the rebuttals I often use when people say, if you bring in a wealth tax, lots of wealthy people will leave the country. And I'm like, well, I'm actually more worried right now about the people who run our NHS who are leaving. The opposite argument to that is this kind of concept that the right often push of health tourism. Does health tourism exist?
So for people who don't know, health tourism is people who are coming into the country to use our NHS who aren't entitled to the NHS. And the long and short of it is, yes, it does exist, but is it crippling the NHS? And the answer to that is no. Health tourism takes up about 0.3% of the NHS budget. So anything that takes up 0.3% of the NHS budget is not the reason the NHS is under pressure. Lots of people will point at it because it's dog whistle politics, and they'll say, oh, look, there you go, it's them who are doing it. And they often point to people like myself of colour, not and people who might look different to them. What I would like to say is people like me, second generation immigrants or people from historically marginalised groups, make up a massive proportion of the people working in the NHS. And when it comes to doctors, we make up nearly half of the doctor population within the NHS. When it comes to nurses and midwives, we make up about just over a third of the numbers of NHS midwives and nurses that you see. So we are not the reason that you can't get an appointment. We are not the reason you can't get that scan, or we're not the reason you're waiting months, if not years, for your hospital appointment. We are the reason you can get an appointment. We are the people who are working to ensure everyone gets equal access to health or care when they come in. And so it really does pain me to hear about that, because it's just not factual, and all it does is isolate historically marginalised groups of people. And there's so much of that going on in the NHS, outside of the NHS, in the media, wherever you look. And that is just another example of it. And it's so painful because the opposite is true.
Chris Packham here, Chief Ecologist for EcoTalk. It's a bit of a big day for me because I've come to answer to the boss.
If we were a conventional company, Chris, we'd be talking about turnover, rates of return, shareholder dividends, all of that kind of stuff. But you know that we're not a conventional company, and our bottom line is a very different one. It's about nature. It's about birds, bats, bees, ponds, beavers. Tell me, how are we getting on?
Well, I'm pleased it's not the former because I don't know anything about that, but I can tell you that EcoTalk is paying massive dividends for wildlife. Yes, the ponds are in, the trees are in, the wildflowers are in, the bird boxes are up. The barn owls are prospecting in the boxes, and we've got beavers and more beavers coming. Dale, the company is booming.
Fantastic. And subscriber numbers are booming too. I mean, I think we have quadrupled in 6 months. We're at 20,000 people. And this is what's powering the whole venture. People's mobile phone bills, allowing us to do this for nature. I love it.
It's absolutely fantastic. Do think about joining up. ecotalk.co.uk/boldpolitics.
We're talking a week or two after the Gorton and Denton by-election where Hannah Spencer won, and we're actually speaking the day after her maiden speech, and then just watching it just kept welling up over and over again. For anyone who hasn't seen it, there's a section where she names every trade person under the sun and just says this is for the posties, the plumbers, she just keeps listing them, and it keeps going on and on and on. But I just know from knowing Hannah that she'll have sat there for a long time and thought, oh, this group of people and this group of people, and not wanting anyone to be left behind. And these jobs that are so rarely seen or heard about.
Yes.
It just felt really special.
Amazing.
But I remember being on TV the morning after. I think it might have even been Naga Munchetti, actually, but it might have been someone else who said to me, why did you put out leaflets in Urdu? And I genuinely wasn't trying to be sarcastic, but I just said, I think we put out leaflets in Urdu because we wanted to communicate with people who speak Urdu. And just pausing and going,
I saw that.
No more complicated than that.
Honestly, it really blew my mind because in the NHS,
right,
for cervical screening, for bowel screening, breast screening, immunisations, if we know a certain household or a certain population don't have English as their first language and they're more comfortable speaking or reading in another language, we send them a leaflet in that language,
right,
because I don't care what language you speak or read. I want you in for your breast screening. I want you in for your immunisations. That is the overriding thing. And it is the same in politics. It doesn't matter what language they speak. It just drives me mental. So I was watching you during before and after that, and there was a real push from people saying, well, do you not think you just got the Muslim vote? Or this was all about one single condition? Like, Muslims are one homogenous group that only care about one thing. We care about the exact same things that everyone else cares about. It doesn't matter what language we speak. It doesn't matter the food that we eat. We still care about the cost of living crisis. We still care about how good education is in schools. We still care about access to the NHS. We still care about our environment. We don't have one single issue that is Gaza. Of course we care about Gaza. Well, not all Muslims do. I certainly do. I can only speak for myself. I'm not going to speak for a whole group of people. But I care about all those other things as well. And lots of Muslims I know feel like I do. We're not, and it drives me mental when I hear them say, oh, well, the Muslims only have one issue that they care about and you're doing that just for them. Honestly, we care about everything else. I want the kids in my family to have a great education. I want them to be able to be safe when they play outside, and I don't want them to breathe in dirty, car-ridden air. I want them to be able to go to the woods and see wildlife. I want them, all of that stuff. I want the same as anyone else from any other background. And I want that for children right across the world. And that is why we care about some of these other issues as well. And so, yeah, I did see all of that. And it didn't get me angry. That isn't the right word. It just made me really sad that that they can't see us in anything more than that very tunnel vision version.
I feel it deeply too as a Jewish person, that it's often referred to as the Jewish community, and I'm like, there is definitely a diversity of opinion among the Jewish communities, and it's exactly the same in Muslim communities, right?
Yeah, very much so. If you go to my mum's house on a Friday night where there's a load of them all congregated together, they'll just be arguing about different issues because they've all got different opinions on things, same as everyone else. It is exactly the same. And this kind of differing of it. Your original question was about the leaflets in Urdu. Who cares? Who cares? Should we only send English leaflets out to people who might miss their screening as a result of it? Is that what this person who asked wants? Is that what he or she wants? So, oh well, you don't speak English, so we sent you a leaflet for your bowel screening. You didn't come to it. You got bowel cancer. It's your own fault. Is that what you want? It's crazy.
And I suppose it's a deeper question. This definitely, I'm not talking about one individual here, and I'm certainly not asking you about your colleagues. I'm not trying to get you cancelled here for a second. I'll put you in an awkward place. But when people ask these questions, particularly if they're people of colour, presumably they know what the answer is. So are they asking the question because they feel like they need to go through the motions? They're being told to ask the question? It's kind of laziness? I
genuinely don't know the answer to that. I just wish that they would think a lot more about what that means for so many people who are listening to the question, understanding the undertones in that question, and what it means long term. Because even the questions like why did you send them out in Urdu, or is there only one issue, has really kind of wide-ranging consequences over a long period of time for all of us.
Absolutely.
And it's really important that journalists understand that.
There's lots of other groups where that question would be dealt with a lot more sensitivity, but it feels like there's a particular, Islamophobia is, I think it needs to be named. And I think there's a lot of Islamophobia on our media and in our public discourse.
Yeah, I think there is. I think there's so much division across religion and colour and class. And yes, we can talk about Islamophobia because that is a big one. But I don't want to talk about that and then ignore the others as well, because you're Jewish. Anti-Semitism is on the rise as well. And that absolutely needs to be recognised. They are both just different sides of the same coin. If you tackle one and not the other, you're not actually helping anyone in that situation, because the other group will feel isolated and feel like you're not doing anything for them. And so it's so important that any kind of prejudice gets called out or at least recognised for what it is. And I do, both Islamophobia and anti-Semitism are on the rise. A good example is, recently I can't remember exactly where it was, but an explosive device was found in a mosque, and it wasn't even news. It just didn't make any of the news until days later. But if that had been anywhere else, it would be the number one headline everywhere, as it should be.
Right.
In any church, any synagogue, any temple, it should be the number one, because any religious hatred is absolutely disgusting and should not be tolerated. But it should be equally not tolerated across the board.
And with that, we're hearing about a worrying rise of racism within hospitals or to healthcare staff, of people being intolerant of people with brown or black skin or who have an accent. What does the NHS need to do? I mean, as I'm asking, it's very obvious it's zero tolerance, but I guess, is there anything else?
Apparently we have zero tolerance, right? And it's just not being... I've been in meetings where a patient has said very clearly racist things to a colleague of mine. They have brought it up in the meeting, and not everybody, a lot of the people have said, oh, well, let's just move on from this and we'll learn, and we'll send him a letter saying, don't do that again.
This among staff. I was talking about patients to staff, but it's happening staff to staff as well.
Well, no, that was a patient to a staff, so it came to our meeting. But racism is on the rise. Intolerance is on the rise. All of those things that affect us who work in the NHS is on the rise, but at the same time it's being normalised. So people feel emboldened by what they're seeing on television, by some of the conversations that are happening within politics and by certain politicians. And so when it is normalised, when people feel, actually, no, it's all right for me to say that, the P word is not that racist, really, isn't it? It's just shortened for Pakistani. That's the argument. And so when they say it, they don't realise the history behind it, or they do and they don't care. And so they are emboldened to say it. The NHS goes, well, actually, we have a duty of care to that patient, so we've got to look after them. Let's just give them someone else who looks after them rather than you. But they have a duty of care to us as well as people who work there. And zero tolerance should be zero tolerance. And I think for a lot of the time it is. I don't want to say that this is happening everywhere. For a lot of the time it is, but not all the time. And it should be all the time.
Yeah, I think it's, even if it's just one incident, and we know it's more than one incident, the idea that it would just be brushed under the carpet or seen as, oh, this person behaves in that particular way.
Yeah.
Just really challenging those concepts.
Yeah, very much so. And that isn't happening. And people need to know that if you use those kind of words anywhere, it doesn't matter whether it's in the NHS, outside of the NHS, there should be absolutely no tolerance for it whatsoever. We grew up knowing that kind of behaviour was unacceptable. Suddenly it's become acceptable again.
Right.
And it's been such a insidious process, and we've got to a point now where whether you're black, white, brown, whatever, there's a chance you could be, verbally abused for the colour of your skin. Everybody will feel different about it. I will think, brown and black people will feel discriminated against. But obviously, there are some people from white communities who feel they're discriminated against as well. And yes, we've got to understand that. But I feel like when it happens there, it's like, right, let's try and understand it. Let's figure out what's gone wrong. When it happens anywhere else, that same level of understanding doesn't occur.
Yeah, I think that's totally right. I was going to say separate subject, but to be honest, it's the exact same subject, which is mental health. And that's about the mental health of the staff. But more widely, there felt like there was a push a few years ago to mental health to have parity with physical health. Have we got there? And if not, what more needs to be done?
No, we definitely haven't got there. A lot of the consultations I do in primary care have either are all mental health or have a mental health kind of vibe to them, or an angle to them, because their physical health is affecting their mental health. And I know that if I refer someone for a community mental health service, either it's going to get rejected because they're not bad enough,
right,
or it's going to be really hugely delayed, and in the meantime they can go online and read this website, and that's really sad. I know that patient's going to leave the room, and I'm not going to be able to do the best thing for them. And then the question around what more can be done. Yes, we do absolutely need more accessible mental health services, But you need to look at what's causing all these mental health issues. And it can't just be, let's just tackle the top end. We've got to go right down to the root. And a lot of it goes, I think, I'm a big fan of community. I'm a big fan of people from different backgrounds coming together, learning from each other, but also working together in things like youth clubs and community centres, all the things that we used to. Well, I don't know how old you are, Zach, but if you're around my age, we had growing up. And I remember going to the youth club and playing pool with people that I would never have met otherwise. And it was a great pleasure, but it was also a great learning experience for me in hindsight. Obviously, I didn't know that at the time. I was very young, but now I do. And we just don't have that anymore. And so I think getting back to community, getting back to that kind of it takes a village mentality is really important. And I think certain groups have that. We certainly have it within our South Asian community, and it really helps. I know when my father passed away many years ago, what got my mum through it was the community, and that idea of social isolation doesn't really exist for my mum because she's always got someone there who we know she can go to, or someone's always round at the house, and so I love that for her, and I want that for everyone. And I'm going off on a tangent now, but mental health affects so many people at different levels. Within school, what are we doing within schools? School nurses are incredible, but they're so stretched. They're only in a school maybe one day a week, and then they go to a different school and a different school. So why don't we have a someone based out of school who looks after the children's mental health all the time? They can just knock on that door and say, look, miss or mister, or sir, I am feeling a bit stressed today, or this exam is feeling overwhelming, or this homework's feeling overwhelming. Can I just talk to you about it rather than having it all bottled up? But to get access to a school nurse, it is, she's only in on a Monday, or he's only in on a Wednesday, so you'll have to wait till then. And by which, for a child, that's really hard. And then as we get older and older, different things affect our mental health. So you've got to look at, again, I go back to the cost of living, but that's a massive cause of pressure on people's minds. So what are we doing to take that pressure off? Right now, absolutely, we're doing the opposite, aren't we? Because we're going to, oil prices are going to go up, and that's going to cause a nightmare for people who are already struggling right now. Food prices are going to go up, and that's already going to cause a massive pressure. And that's going to mean that people can't afford fresher food, and they're going to go to more ultra-processed foods, and then their health is going to get worse. And it's just a horrible, vicious cycle of doom. But there are things that we can do, which I'm hoping you have the answer to.
It's so funny here you talk about grim things because you're so smiley and positive, and I'm like, you're talking about like the collapse of civilization, but with a huge smile on your face, it's all going to be okay.
I'm crying on the inside.
There's a brilliant social scientist called Kate Pickett who co-wrote The Spirit Level a few decades ago now. But she's just written a new book, which I just kind of read the first draft of. And she has this amazing metaphor in it, which is a cliff edge. And she says very often people have fallen off a cliff, and so much of our intervention in healthcare is the safety net. Like, what do you do after people have fallen off a cliff?
Yeah.
She said a few years ago, we started to focus more on like when someone's about to jump, how do you talk them down from it?
Yeah.
But she was like, what if we just didn't have a cliff? And what actually if we help people so they didn't even need to feel like they're even in that place in the first place? And I feel like you just described that.
Yeah, I think that's right. Because we always encourage people to talk about their mental health, don't we? Talk about it. But what are you going to do about it once I start talking about it? And how do we, as you say, how do we stop people from getting there? There's so many layers to it, but it has to start young. That support for mental health has to start young and carry on through to adulthood.
I feel like everything we've spoken about so far is encapsulated a little bit in Palantir, which, for those who don't know, is the US tech spy firm that we have given contracts to with the National Health Service. It does have a break clause next year. And obviously, I've been pushing for the government to take that break clause. Where do you stand on Palantir? I was going to say, how concerned are you? But that's a very leading question. How much do you love Palantir?
I don't love it at all. I have serious concerns about it. It has been given this huge contract, £330 million, which is massive. And what it is supposed to do, it's a data, it collects massive amounts of data.
Federated data.
Yeah, federated data. So it can be used in, it's an operational use of data. And they've been given an NHS contract so they can do that too. Our data, our patient data. And the idea behind it is, we might be able to manage waiting times better, discharge outcomes better because we've got all this data. That's the idea behind it. However, there are serious concerns. I think the first thing that I would say is that the Swiss Army said no to Palantir coming into Switzerland because they were concerned that they would share Swiss data with the US government. And also, I'm very concerned that Palantir are hugely involved with Homeland Security in the US, and particularly with ICE and the deportations that we've seen. And they've used the data they have to identify people for ICE to target, to put into these awful detention centres and then subsequently deport and split these poor families apart. I'm also concerned because Palantir have very clearly said they are working with the IDF in Israel, and they are helping them collect data, and that has had devastating consequences for the people of Gaza and beyond. And a company like that has no business being in the NHS. It has no business. We don't know what they're going to do long term with our data. Where, of course, the government will say that there are safeguards in place and the data doesn't belong to Palantir. It still belongs to the NHS. But we've all heard of data leaks. We've all heard of these, dark companies that can do all of these things. I don't think, and even if you don't know about Palantir and you don't care about those things I've just said, if you're why are we using foreign companies to come and to mine our data? Why can't we use a British company? Also, can I just say that Palantir has also got links to Lord Mandelson as well. And that can't be a good thing because we all know now that he was linked to Epstein even after he was convicted. And so there's too many red flags here for us to say safely, actually, no, let's have this company mine our patient data. We don't know what's going to happen in the future. They may use that data for lots of different things. What if they do start using it to profile people and target them and all of this stuff in the future? I just don't think it's a company that belongs in the NHS. And if we leave it too long to sort it out, we'll become entirely dependent on them. The NHS will become entirely dependent on them, and it will be too hard to unpick it at that point.
I mean, listening to any one of those red flags sounds like a really, really bad idea, and you put them all together and you go, this really is catastrophic. Looking for some of the nuance in what you just said. So they're looking to bring all the data together. Is that, presumably that in and of itself is not a bad thing? Or
No, that's definitely not a bad thing. I will say right now, the NHS data systems are not talking to each other. For example, if I see a patient who has not long been in hospital, often I haven't got the information from the hospital by the time they come and see me. And so there's a lot of ringing around to send an email so I can see it. So we do need a system within the NHS where a patient goes into hospital and I can see that live on my system as well, what their bloods are doing, what their oxygen sats are doing. So, and I know they're coming out on this particular day. So I might say, okay, right, that's someone who is coming out of hospital, probably needs an extra bit of support from our community matron. Let me put that in place. So yeah, we need all of that to happen. We can't have delays in those kind of things, but we need an ethical company to do it. And I think that's the issue.
That makes total sense. And so if anyone's concerned about this, what kind of do you want them to do about it, or how can they get involved?
You can write to your MP and just say, I'm concerned about Palantir having my data, my own personal NHS data. You can write to them and say that and get them to act on your behalf.
I've just realised I should promote too. I've done a petition with 38 Degrees. So if you search Palantir 38 Degrees, also please sign the petition as well as writing to your MP. That's really, really important. Finishing up, if you, and this has been amazing, thank you. I've really enjoyed. Feel like I've been absorbing and learning in real time whilst enjoying the conversation. So hopefully everyone else has too. You're Minister of Health. What are your priorities? What are the first things that you think need to happen?
So the first thing, let me think about this. So the first thing I would do is try and understand why the staff in the NHS are so unhappy, and whether that is pay and whether that's working conditions, and what we can do to support them and over what length of time. I understand there isn't a magic money tree that we can give everyone the pay they need, but is there increments we can work towards so they know that it's coming? And what can we do in terms of looking at investing in staff, looking after their mental health so they stay within the NHS and they're able to give patients the care that they need. I think that's my number one priority. I would also look at how we can support primary care and community care so patients can be looked after at home. So I go back to what I said, so primary care is such a multidisciplinary team of people looking after patients in the community. So let's work with that. So if a patient rings up with a certain problem that's best suited to a physio or an OT or a nurse or a district nurse, we send them directly there. But then the GPs who might need to look after a more complex case have the time to do that. And so we give them the longer time and space to do it. And if patients do need looking after at home in terms of these really specialised services like the heart failure nurses, but we look at all of that, frailty nurses, falls teams, all of these going out to people's homes to really minimise the risk of them coming back into hospital or needing hospital, I think is key. And that long-term preventative chronic disease management plays a massive part in that. I would also look at the infrastructure of the NHS. It's a crumbling kind of thing at the moment. We haven't invested in infrastructure for so long. That is the physical buildings, but also the IT systems, as you've described. And then you can't have a good NHS system without good social care either. And so they need looking into, and that bed flow, making sure that patients who don't need to be in hospital are not in hospital. I would invest back in community hospitals again, where they can have all that rehab. And then I'd invest in social care. So that flow from hospital to intermediate care to social care to home happens seamlessly. That's what I would do.
I mean, it all sounds like a pretty amazing agenda. Dr. Khan, or Amir, as you told me to call you, thank you so much. It's been an absolute joy.
My pleasure. Thank you.
Hey, Zack, EcoTalk was set up to use its profits to help restore nature. There's a biodiversity crisis going on, and we need bold ideas to solve it. You're a bold guy, Zack. Your audience like bold actions, and we're bold at EcoTalk. We're making a difference at our rewilding sites across the UK. The more people that join EcoTalk, the more great work we can do. So come on, join us. Go to ecotalk.co.uk/boldpolitics.